Hello and welcome back everybody to the afternoon session. I hope you've enjoyed the day so far and that it's been insightful and helpful to people. My name's Sarah Sibley. I'm a respiratory consultant at Liverpool Heart and Chest Hospital. There may be some people that I know on this call. This afternoon, I've got the great pleasure of introducing a number of colleagues from across Cheshire and Merseyside to share some more information about interstitial lung disease and the management of it. This is really a session that's here for the people that are on the call who are either living with interstitial lung disease or caring for somebody or have friends or family with this condition. So we want it to be helpful, and if you ask any questions that you've got in the question and answer box, we will make sure that all questions are answered. It may be that they don't get answered during the live session this afternoon because we only have limited time, but all questions will be answered either in the question and answer box or live through the session. So now we're back up in Cheshire and Merseyside. I have the great pleasure of introducing the first person who's presenting this afternoon, who's Louise Brockbank. Louise qualified as a lung consultant in 2018. Having been working at and has been working at St Helens and Knowsley Hospital ever since. So some of you may have seen her as your consultant. Throughout her training, she's been working in Merseyside and has always had a really keen interest in managing people with interstitial lung disease. So when the opportunity arose to take up a lead position in this, she grabbed it, and she works with a team of respiratory nurses and oxygen specialists at St Helens and Knowsley. So Louise is going to talk to us about anti-fibrotic drug therapy, and I will hand over to her now.
Hello everybody. Like Sarah said, I am firstly I'm really grateful to have been asked to speak today, but also I'm really hopeful that some of my patients across Knowsley and St Helens are listening in, and so hello to anybody I know. So we're going to talk about anti-fibrotic drug therapy. First, and probably the most important question for all of you listening in today is, when can they be prescribed? Really, there's two groups of conditions where we can give these medication. Many of you listening will have already been prescribed for idiopathic pulmonary fibrosis. Now, it's important to note that, firstly, idiopathic pulmonary fibrosis is a disease where there is no external cause being recognised for the scarring developing. The antifibrotic medication given in this circumstance are issued by, the criteria in which we can give them come from NICE, which is the National Institute of Clinical Excellence. The decision to give has to be made through a multidisciplinary team meeting, and in Merseyside our local MDT is Aintree Hospital, who are obviously hosting our session today. The second group of patients that we can give these medication to, it's a newer indication, so many people may not have heard this yet. Progressive fibrotic ILDs, this indication started in February this year, and of the two medication that we can prescribe, it is only nintedanib that can be given for this indication. Usually it's conditions which have been treated with immunosuppression, which I know Dr. Simmons is going to talk about later. They have already been treated, and in spite of the treatment, there is progression in the scarring. And like I've said in the slide, your clinicians will be looking out for this. If you're not sure, then do ask the doctor that's looking after you with your lung complaint. So, as I mentioned, there are two antifibrotic medication, Esbriet or pirfenidone, and nintedanib, which is also known as Ofev. These medications are fully licensed. They have been assessed and are approved for use in the NHS. They are not experimental treatments anymore, nor have they been for a long time. It's important to just mention, as I will mention a few times during my talk, that these medications are given with the intention of slowing down the disease process, slowing down lung scarring, and slowing down the buildup of scar tissue within the lung. They don't stop lung scarring completely, and they don't get rid of any scar tissue that has already formed. And they're also costly treatments. So if you look up on the British National Formulary, which is, as doctors, our go-to place for how we prescribe medication, The cost of treatment for a year there is quoted at £25,000. So what do they do? Basically, both pirfenidone and nintedanib have been proven in large trials to slow the speed at which the lungs are getting smaller. So I've just picked this graph out of one of those studies. The first slide here is about pirfenidone. So on the vertical axis on this graph, which is the one on the left-hand side, we're looking at change in vital capacity, change in forced vital capacity. So as you go down, you're seeing a loss of lung function and the lungs getting smaller. And on the bottom side of the graph, on the what we call the x-axis, we've got time. So this is going through the weeks up to a year. And the two lines that you see on the graph, the top one is those patients who have been given pirfenidone, and the bottom line, the lighter blue, is those patients who've been given a placebo, so a non-active pill. And in summary, what this graph is showing us, that over this year period, that the rate of loss of lung function is halved in those patients that are given pirfenidone. Obviously, this study was done before we proved that these medication work. So those patients that were not given the pirfenidone weren't being not given a treatment that we knew was effective. It was still in trial at this point in time. Similarly, looking on to nintedanib, actually we see very, very similar results with nintedanib. So again, on the vertical axis on the left-hand side of the graph, we've got change in the forced vital capacity. So as you go down that axis, we're seeing a loss of lung function. And across the bottom of the graph, we've got progression of time. So weeks again, up to a year point. And the top line on this graph, the darker blue, is nintedanib, and the bottom line, the placebo line, is those patients who've not been given an active ingredient. I should note as well that this is idiopathic pulmonary fibrosis patients, not all patients with pulmonary fibrosis. So the top, basically, again, in summary, what we're seeing across the course of a year is that those patients who've had nintedanib, they have lost half as much lung function as those patients who've been given placebo. So what is the aim of giving treatment? So just reiterating this, we are aiming to slow down the buildup of scar tissue within the lungs. The aim of giving treatment is that patients with pulmonary fibrosis will live for longer, and there is evidence to back this up. There is also a suggestion, and this is really still to be worked out, that maybe these medication will reduce the chance of having a flare-up of the lung disease. It's also important to note what they don't do. So neither nintedanib nor pirfenidone get rid of any scarring that is already present. They also won't stop lung scarring from getting worse altogether. They are slowing down the scarring worsening, not stopping it. And they won't improve symptoms. Now that makes sense because they're not undoing any of the scarring that is already there. So symptoms that are already present won't improve on these medications. The lung disease will still get worse over time. And this just reminds me of something I remember Dr. Lisa Spencer telling me when I was still in training, which is that it's good to think of these medication like a pension. You need to pay into it to get the benefit later, but you don't feel better for paying into your pension at the time. Okay. Clearly, given that we've already said that symptoms will continue, and actually because we know the lung disease will progress over time, symptoms will gradually also worsen. It's important to consider other treatments. And so clearly as well, if you have idiopathic pulmonary fibrosis and you're not yet eligible for antifibrotic medication, or if you have tried medication and they've just not agreed with you, other treatments that are supportive are really important. So you will likely already have talked about some of these things with your doctor if you have idiopathic pulmonary fibrosis. Morphine is a really helpful and important treatment that will reduce cough and breathlessness. Lorazepam will also be helpful in treating any breathlessness. And I know we have a session in a bit about oxygen therapy. Your doctor will probably have talked to you about pulmonary rehabilitation, which is an exercise-based program run by physiotherapists, which often patients find really helpful in terms of knowing how to manage breathlessness and how to manage doing activity. So there are side effects. These medications are generally quite well tolerated, so not everybody has side effects. And it's important to note that with either pirfenidone or nintedanib, that when the medication is stopped, the side effects go away. But they do occur, and they're often manageable, but sometimes it will cause a patient to need to switch from one medication to the other. So with pirfenidone, the things that people notice are sun sensitivity and rash, which can occur about 1 in 5. There can be liver problems. Now, there will be blood monitoring, and as long as the blood monitoring happens as it had been advised, this is not something to worry about or consider to be a danger. There is a significant chance of stomach problems, about 15% of people, and also feeling tired, which is a really sort of non-specific symptom, but does occur. Moving on to nintedanib. Again, not everyone has side effects, and these can be managed. So there is a chance of liver problems. Again, like pirfenidone, about 1% of people will have to stop medication altogether because of this. There are stomach problems, and about 1 in 20 people will stop this medication because of side effects, particularly diarrhea. That is manageable, so often changes in diet or use of loperamide will mean it is possible to keep taking the medication in spite of that side effect. There is a possibility of an increased risk of bleeding and stroke. So if you are on blood thinning medication or you have had a history of stroke, the doctor that you see in clinic may not recommend nintedanib as a first-line treatment if you have a history of those. So in summary, anti-fibrotic medication do help people with idiopathic pulmonary fibrosis to live for longer. But alongside these medications, it's really important that we also manage symptoms. There are side effects, but they don't usually stop people from taking the medication altogether and are usually manageable. And that's it from me, so I'll hand back to Sarah.
Thanks so much, Louise. We've got lots of questions coming in, but I'm going to save all the questions for once we've heard from all of the other speakers. So it's my great pleasure to introduce our next panellist, who is Anneliese Simons, a chest consultant at Aintree Hospital. She started post in January 2019 and specialises in interstitial lung disease. Welcome, Anneliese.
Hi, thanks very much, Sarah. Thanks for letting me to speak today. I'm sorry I missed the morning, but it's great to be here for the afternoon. And I'm going to speak today about immunosuppression in interstitial lung disease. So what I'm going to cover today is when we use immunosuppression and when we don't use it, why we use it, what sort of immunosuppression we use and how much we tend to use. So what I've done here is just try to demonstrate really with this diagram that interstitial lung disease is a very wide spectrum of disease. And at the one end where it's all very blue, you can see that inflammation is the predominant or only feature in the lungs. And then at the other end of the spectrum, where it's all yellow, the scarring is the predominant feature. And like all spectrums, there's black, white, and there's grey in the middle. And in the middle, you have diseases which have probably a combination of scarring and inflammation in different quantities. So what I've done here, I think you may have had a talk already in terms of what some of the CT scans might look like in interstitial lung disease. As you can see above the inflammation, above the word inflammation, you can see that the lung tissue looks very sort of hazy. We call it ground glass, and that sort of change in the lungs can actually respond very well to immunosuppression and is potentially reversible. On the other hand, the scan above the word fibrosis shows what we call scarred lung, and you can see that the arrows are pointing to lots of little circles in the lungs, and we call that a sort of honeycomb change because it looks like beehive honeycomb or marbled steak, as one of my patients said to me the other day in clinic. And what that is permanent scarring and damage in the lung that is irreversible. And some people will have a disease that has a combination of these two effects. Oh, I've just lost my slide connector. Oh, there we go. So in terms of when we use immunosuppression, we use it predominantly or really only in inflammatory lung diseases. So there's some examples of this. I've just listed down my slide here. So acute hypersensitivity pneumonitis is basically a lung disease where your lung is having an overreaction to something it's been exposed to. And many of you will have heard of something like bird fanciers lung or farmer's lung, where the lungs are just sort of overreacting to the exposure that they're having. And the next one down I've mentioned there is autoimmune related disease. So these are sorts of connective tissue diseases like rheumatoid arthritis or that family of diseases where you get some inflammation in the lungs and also in other parts of the body as well. Sarcoidosis is a disease in its own right, really, and can affect any organ in the body, but it commonly affects the lungs and tends to cause a very inflammatory response in the first instance, much like we can see in the picture there. So when we don't tend to use immunosuppression is in that fibrotic or yellow end of the spectrum, scarred lung disease. So one of the most common things that we see in our clinic is something called idiopathic pulmonary fibrosis or IPF, which many of you will have heard of, and Louise has just spoken about the treatment of that. The other disease that we often see in our clinic is something called asbestosis, and this is in terms of how it looks on the CT scan, very much can be very similar to idiopathic pulmonary fibrosis, but the difference is that there is a history of exposure to asbestos, which causes that scarring process in the lungs. So what do we use when we're talking about immunosuppression? Well, what we tend to use in the first instance is steroids, and steroids are great from the point of view that they have a quick onset of action. So if we see someone in clinic and we want to treat them, and get a response quickly, we often use steroids to get that initial response. As many of you will know, those steroids have a very long list of side effects, like many drugs, and therefore we don't often like to keep people on steroids long term. So we look at the second line of medication, which are things like methotrexate and mycophenolate. And these medications also have side effects, but they are often quite well tolerated in our clinic, and they have a same effect in terms of steroids, but with less side effects, and patients can be on these medications long term. Occasionally we do use intravenous therapy in the form of cyclophosphamide, and we use that in patients who are really very sick with very severe lung disease that we feel need some very quick action, and we don't actually use it very commonly, but we do use it when needed. So why do we use immunosuppression? What is the aim of using it? Well, as I've mentioned already, that change that we saw on the scan in the early slide that I showed you, that hazy kind of ground glass change, is potentially reversible. And so by starting the immunosuppression, we're aiming to reverse some of that inflammatory change. We also, along with that, would expect to see some improvement in symptoms as well. What we're aiming to do with the treatment is to actually dampen down the immune system's response to whatever, to the exposure or to the autoimmune disease, to prevent further change from occurring. And really, most importantly, what we don't want is that inflammatory lung disease that we have seen on the left side of the slide, or in the blue area, to change into that scarred lung that we see on the yellow end of the spectrum. So what's the evidence for using immunosuppression? Well, this is just a graph that we've taken from a study that was done in patients with scleroderma and lung disease as a result of scleroderma. And what this shows is that patients who were taking the active drug, so the blue line, over a period of time, their breathing test improved on the treatment, compared to the pink line where the patients were on a dummy drug, and actually, unfortunately, their lung function declined over a period of time. So we know that immunosuppression does improve lung function with time in patients with inflammatory lung disease. On the other hand, this is a graph taken from a study looking at patients with idiopathic pulmonary fibrosis. It's a very famous study that many of you may have heard of called the Panther study. And in this, the patients who are on the red line, that combination therapy, are on immunosuppression combination therapy. And as you can see, over a period of time, the number of patients that died or had to be hospitalized was actually higher in the treatment group than the patients taking the dummy drugs. And what this shows is that we shouldn't be using immunosuppression in patients with idiopathic pulmonary fibrosis. Having said that, we do use sometimes very low doses of steroids in patients with idiopathic pulmonary fibrosis, not to treat the scarring of the lungs, but to help with holistically with perhaps sometimes appetite, boosting appetite, because often when people have advanced lung disease, you can lose a lot of weight and you're in a sort of high metabolic state, really. So that's why we would use like very low dose steroids in that group of patients. So how much do we use? Well, that's a really good question. And what we tend to say is we want to use the very least amount to achieve our aims. Every medication that we give, we have to think very carefully about, because with the benefit, there also come risks and side effects. And giving too much immunosuppression can cause a very increased risk of infection, which in itself can be detrimental to the lungs. On the other hand, giving too little doesn't achieve the aims that we mentioned earlier in terms of improving symptoms, reversing the inflammatory change, and dampening down the immune system. So in terms of what the future holds, there's currently a study ongoing at the moment looking at a combination of using immunosuppression and antifibrotic therapy in those patients who are perhaps in that grey end of the spectrum, where they have a combination of inflammatory and fibrotic lung disease. There's also the possibility of using combination immunosuppression, and like many areas of medicine, we're looking at really trying to individualise treatment as best we can. Thanks very much. And oh, sorry, put it on to the next person's slides. Thanks very much for listening, and we'll have a look at the Q&A shortly.
Thanks, Anneliese, for another great presentation. We're going to move on to our next speaker, and the questions are coming in, well, speakers, I should say. The questions are coming in thick and fast, which is great, and we'll try and address all of those once all the speakers have finished. So it's my pleasure to now welcome two specialist respiratory nurses from Aintree Hospital, so Joanne Sutcliffe and Jenny Webb. They've both worked in respiratory medicine for many years, and they both work in the interstitial lung disease service and also support patients with oxygen prescriptions. So they're here to share their knowledge and expertise. I'll hand over to them.
Hi, thank you very much, Dr. Sibley. It's very nice to have been asked to speak today. Jenny and I have been asked to speak about the breathe ins and outs of oxygen this afternoon, and I'm going to take lead on that talk, and then I'll hand over to Jenny. So why bother with all the faff is the question, and it is an important question, because for any of you out there who already have oxygen therapy, you will know that it is delivered in the home by equipment, and that can and does make life more complicated. So it's really important that any therapy we give you has a benefit for you. So what I wanted to look at first was actually, how do we get oxygen in the body? And I've got a diagram here of the lungs and the alveoli of a patient who doesn't, of a person who does not have lung fibrosis. And as we breathe, the air flows down the trachea into the bronchial tubes and then down to the alveoli. The alveoli is a balloon-like structure, and that expands as we breathe in. The lining becomes really thin, and the oxygen is then allowed to pass over into the blood vessels that surround the alveoli. And as you can see from the diagram, it's very vascular around there, and the oxygen is then transported around the body by the bloodstream, and vice versa with the carbon dioxide. That is a really efficient system and works very well for the majority of people. However, obviously, if you have lung fibrosis, something changes. So on the next slide, we can see that we've got some diagrams of an alveoli, which is a normal alveoli, and then one on the right where you can see there is scarring or fibrosis, and also it can occur with inflammation. So the lining is much thicker around that area. So when you have pulmonary fibrosis, you get a buildup of that fibrosis or scar tissue in this area, and that limits how efficiently the oxygen gets across into the bloodstream. So if the body's not able to get as much oxygen into the bloodstream, we cannot oxygenate the cells and the organs as well. And this then can lead to breathlessness, muscle fatigue, and just general tiredness. So from your perspective, you're at home and you're noticing a change in your breathlessness over time, which often feels worse during exertion. It's important to highlight this to any of your clinical team, and that might be your oxygen team or your local respiratory doctors or nurses. If it's an acute change over a week or two, that's more usually a cause of an infection or an exacerbation. So we're looking at actually a gradual change over a few months' time, where you're thinking, actually, you know, I can't go up the flight of stairs as easily as I did. I'm having to stop halfway up, or when I go for my morning paper, I'm having to stop once or twice as I go there. And these are important indicators which might make us think that the breathlessness is actually changing for a specific reason. It's important to acknowledge that actually breathlessness is caused by many reasons. It's not just due to a drop in your oxygenation, and actually identifying the cause is part of the process. We also need to remember oxygen is a drug, and it needs to be given following careful assessment. We need to ensure that you as a patient gains benefit from it, and it needs to be prescribed. So when we talk about oxygen, there are several different types, but for the sake of today's talk, we just want to focus on two of them. So one of them is ambulatory oxygen, and this is often referred to as AO2, and it's used usually during ambulation or exercise, and long-term oxygen therapy. And this is often, you may see, referred to as LTOT, and that's more of a treatment where you're given a specific number of hours that you need to wear it for. So if you're noticing these different changes, it's important to highlight this to your clinical team, and then they can actually assess, is the breathlessness due to your oxygen dropping, and then they can refer you to the appropriate services. And that assessment will be done in many ways. It may be a clinical assessment when you're having a consultation, and that we talk more into actually when your breathlessness is occurring. Is it overnight when you lie down? Is it when you're out walking? What helps it to improve? Does stopping and resting improve it? It may be that we use the pulse oximetry to measure your oxygen levels, and that might be by a finger probe or sometimes an ear probe. And we may do that at rest as well as mobilising. It may be that we put it on when you've walked into clinic, so we can see actually if there's a difference there. And then by respiratory function testing, which I know has been talked about today, where we might look at the efficiency of the lungs, we might get that result back and think, actually, this has changed. We need to contact the patient to have that discussion around oxygen. Following these assessments, we will then decide whether you actually need to be referred for an oxygen assessment, and if so, which assessment is most appropriate. I'm going to hand you over to Jenny now to continue the talk.
Thanks, Jo. So for an ambulatory oxygen assessment, we use a 6-minute walk test. Other services might use slightly different tests, but they all measure the same parameters. And the main parameter we're looking at is your oxygenation. So via pulse oximetry, either an ear or a finger probe, we're looking to see whether your oxygen levels drop when you mobilise. If you do then meet the criteria for ambulatory oxygen, we'd look at equipment options, we'd do some risk assessments, go through some safety, and give education on how, when, and why to use the oxygen. And we'd do further tests to determine flow rate, and then we'd discuss follow-up with you. So once you've got the oxygen at home, it's been installed, how are you going to use it? So we'd say, by definition, ambulatory oxygen is oxygen for use during exercise and activities of daily living. So things like washing and dressing. We want patients to use oxygen during activity, but also during recovery. And that's to try and prevent the drop in your oxygen levels that might be contributing to some of your symptoms. And most specifically, we're referring to breathlessness. During clinical assessments, we'll look at oxygen levels, and sometimes we see them maintained during activity, but then drop a bit. So there's a bit of a lag in the desaturation, and that happens when you stop. And that's why it's so important to keep the oxygen on for a couple of minutes during the recovery phase. We're aware that asking people or advising people to use oxygen can be a big thing. It can feel like a big change, and it can take some getting used to. And we see this commonly in practice. We suggest using it during any type of activity, any level of exertion, and just seeing when and how it helps you. So it might be initially you just use it at home when you're doing things like washing and dressing, or it might be that you feel more confident and you want to kind of use it when you're at pulmonary rehab and you've got a physiotherapist or a specialist nurse who's kind of there to help you and guide you and building your confidence in wearing and managing the oxygen. So moving on from ambulatory, we want to just talk a bit about oxygen at rest. So LTOT. So you'll be referred for an LTOT assessment if your oxygen levels were low when you were sat at rest. So we normally measure it after 30 minutes or so at rest. We use arterial blood gases to accurately assess your blood oxygen levels. Some teams use capillary samples, which are taken from the earlobe. When we prescribe LTOT, we're prescribing it for use over 15 hours a day. And that's what evidence has found to be the most beneficial. So it's fine to wear it for more than that, up to 24 hours in most patients. It doesn't have to be continuous either. So you could have spells off oxygen and then spells off to go out and things. People often wear it overnight as well to increase their hours of use. And the whole purpose of the LTOT is to increase your blood oxygen levels to prevent right-sided heart strain or relieve right-sided heart strain. Some people will need both ambulatory and LTOT, so that's often two different prescriptions. LTOT's normally slightly lower than the ambulatory flow rate. And if that was to happen, we'd ensure that you had access to appropriate equipment, and we're also happy to change the flow rates, and it was safe for you to change the flow rates between those different levels you needed at home. So we've talked a bit about equipment. We've mentioned equipment a couple of times. Once a clinical assessment is complete and we know what flow rate you need or we recommend for you, we'd go through equipment options. There's a range of equipment available on the NHS, and it varies slightly depending on region to region, the local supplier. We want to emphasise that oxygen is being given to help you, so we try to prescribe equipment that allows or enables you to do the things that you'd like to be able to do. So whether that's going out for coffee, or we hear a lot of people liking to do the garden in the summer months. It's important to know your oxygen team's contact details and to know to contact them if you could think your equipment's not meeting your needs or you want to discuss other equipment options. We've got some examples of equipment here. So some of the equipment delivers oxygen on a free flow basis. So that's a continuous flow of oxygen whilst the equipment's turned on, whereas some deliver just a pulse dose of oxygen and they're breath activated. So as you breathe in, you get a little burst of oxygen on inspiration. So these types of pulse dose equipment are not always suitable for people who breathe primarily through their mouths or people who are on quite high flows of oxygen. But the pictures, as you can see, so we've got some oxygen bottles. They can be portable or static. We've got a portable concentrator, commonly referred to as handbag-sized oxygen, and that does deliver a pulse dose. We've got a static concentrator, often used to deliver LTOT because it generates its own supply of oxygen. You can use it on a higher flow for ambulatory purposes within the home as well, but you've just got lots of tubing to contend with there. Liquid oxygen, we get a big flask installed, and then from that flask you can top up the smaller flasks, which can then be used when you're out and about, so they're portable sized. The conserving device on the end is added to portable bottles, and that they turn the oxygen into a pulse dose supply, so it makes the bottles last a little bit longer, which is handy. So the general point of the slide is there's lots of equipment options, and it's important to know that they do exist, but remember that they might not suit you and your clinical requirement and your lifestyle need. We wanted to flag at this point as well that that static concentrator, so the middle blue picture, is widely used, but they do run from your electricity supply. The oxygen company will reimburse some of the money they use, but there's a degree of flexibility regarding the repayments, but we just wanted to remind people of that, obviously, at the moment. So a further delivery system would be how you physically get the oxygen from the machine into you. So often it's just mask versus cannula. It depends on your preference and also the flow rate needed. There's some things we'd consider, like if you've got problems with dry nasal passages or bleeding nasal passages, obviously a mask is good because it helps relieve the nose dryness a little bit. Sometimes people have both, but the important thing here is it's important you're assessed on the equipment you have, so we know that that flow rate is appropriate for you and your clinical requirement. The last slide from me is just an acknowledgement that there is lots of equipment out there, but we very much realise it could be better. And it's a source of frustration for us as like the clinical team, and we know even more so it'll probably be a source of frustration for patients. This is really an acknowledgement of that. And on that note, I'll hand back to Jo. Thanks.
Thank you very much, Jenny. So just the last couple of slides from us. The next one is holidays and oxygen, something we all endeavour to do and obviously enjoy. And the reason we give oxygen is so that you can get the most out of life. You can get out and about and do things that you want to do. Oxygen, the equipment can complicate things. However, you know, holiday oxygen can be prescribed and supplied to most areas of the UK. The equipment, the prescription for oxygen does include which specific type of equipment you have, and also the mask or the cannulas. But normally once that is done, you can just contact your oxygen company. And as long as you've got consent from the hotel or the cottage or wherever it is that you're going on holiday, that should be able to be just put into your accommodation for your arrival, and then it will be removed afterwards. So, you know, please do speak to your oxygen team if you've got any queries about that. It shouldn't entail a change in your prescription. You should just be able to liaise with your oxygen company direct. Occasionally, you will have to go back to your clinical team for a change in prescription if you're going somewhere or you're doing things where you might need a different type of equipment. Unfortunately, for those patients who are wanting to go outside of the UK, we're unable for you to take the NHS prescribed equipment to other countries. However, there are private companies that you can rent or purchase equipment from, and you know, this can then be taken on the flights or used when you're on holiday. It's a difficult one when you're going abroad. Some flights have very different requirements, and it's important to look at your airlines to see what specifically they're asking for, because some allow you to take your oxygen, the rented equipment onto the flight, and that's what they want you to do. However, many of them don't want you to take your equipment, but they want to actually use theirs on the airline. I think the main advice here from us really is very much have a discussion with your oxygen team and your local clinicians about sort of, you know, you're okay to fly, what your oxygen requirements might be. Plan well ahead. These things can take a little bit of time to sort out. So the more time that you can have to organise these things, then the better. Most patients don't require a formal flight assessment test. It can be done with the information that we have from your oxygen assessments and breathing tests. However, obviously there will be those patients who do. Again, please discuss it with your local doctors and nurses to see what their advice will be, because it will vary depending on the specifics. Obviously, looking at safety, with the oxygen therapy, we always usually advise against using emollient creams due to the flammability. You can access zinc-based sun lotions, and we would recommend those, obviously, if you're going to sunny climates. Just the link, well, it's not a link, but information at the bottom regarding the European Lung Foundation. They actually have a really good section on air travel, but most of the charitable organisations, asthma and Lung UK have also got good sections on this. I know Action for Pulmonary Fibrosis and Pulmonary Fibrosis Trust have all got information on their websites, so please do utilise those and gain further advice about it. So lastly, some take-home messages from us. If you're prescribed oxygen and you're feeling limited by your equipment, or you don't think it's meeting your needs, please contact your oxygen team. It may be that you've had a change clinically and you need an increase in flow, or you need different equipment. It may be that you've gone from winter where you're not going out very much to summer and you've got plans and you might just want a little bit more variety of equipment to meet those needs. So please discuss it with them. Lastly, it's important to remember breathlessness is caused by many things. Oxygen is an important intervention that can give you lots of improved quality of life. However, there are also things that can be used in conjunction with that. Pulmonary rehabilitation, which I know we're going to talk about next. Medications can be used, and also something simple as a handheld fan, you know, has got a lot of benefits and can be very useful when you're out and about. So please look at all aspects, because one size doesn't necessarily fit all. I hope this talk has answered some of the questions that you had about oxygen, and I'd like to thank you again from Jenny and I.
Thanks so much, Jenny and Joanne, for helping to try and demystify oxygen. I think it can be quite sort of overwhelming, can't it, when people first have to use the equipment and start to think about using oxygen. So thank you. And we've again got lots of questions for you when we get to the question and answer section. So we're now going to move on to another absolutely vital member of our multi-professional team in looking after people with lung fibrosis. So I'm delighted to now invite Sam Roberts to come and give her talk. So Sam is a physiotherapist working in Cheshire and supports people with pulmonary rehabilitation, oxygen, breathlessness management, and so much more. So I look forward to hearing from Sam now.
Just pop, I've gone too far. Good afternoon, everybody. Thank you very much for asking me to talk this afternoon. I'm going to cover chest clearance as well as pulmonary rehab, which we've heard a little bit about in some of the talks this afternoon. So chest clearance, mucus, phlegm, your doctor might call it sputum, is something that you do need to monitor the colour of, the consistency, and be aware of how easy it is to expectorate, because managing to clear that mucus can mean that it can reduce your infection rate and it can reduce breathlessness and also cough. Timing of chest clearance exercises, which I'll go through, is variable from person to person. Sometimes you might want to just do it in the morning if that's when you feel that you've got more mucus. However, if you've got a cough that is waking you up at night, then it might be worth trying it in the evening as well. Positioning I'll talk about when we talk about the different breathing exercises, and there's the active cycle of breathing technique, which some of you might be aware of, or positive expiratory pressure, which are both techniques which you can use either on their own or combine them together. It's important to make sure that you are keeping an eye on your hydration levels and humidification of that mucus. And percussion might be something that you're aware of in terms of chest physiotherapy, which is the clapping techniques that people tend to think of as being classically chest physiotherapy. So I do apologise for this slide. It's not very, very clear. I have put the link on at the top there for the actual leaflet if you want to go and have a look at it. There's a lot more information there than just this one picture. But essentially, this is the active cycle of breathing technique. In terms of positioning, you can choose to do this in sitting, or you could use gravity to help move that mucus a little bit more easily by lying on your side or on your back. If you've got reflux, then it's not an lie completely flat, and you may want to use a couple of pillows to make sure that your head is slightly elevated. What we tend to advise is that if you start off on your side and then move over onto your back and then the other side, and spend about 5 minutes doing these breathing exercises in each of those positions. So the first thing that you're going to do as part of this cycle is make sure that you're comfortable and that you have got your breath back. Then you're going to take a deep breath. And when we say to people, take a deep breath, they tend to instinctively take a big breath and they put it all up in the top part of their chest, which is not where we want it. So that deep breath is actually a nice, slow, steady breath in through your nose, trying to make sure that the bottom part of your ribs and the top of your tummy are moving slightly. Hold your breath for a couple of seconds if you can. If that makes you feel really uncomfortable or dizzy, then don't do that. Just take that deep breath in and then breathe out. And you're going to repeat that 2 or 3 times, and then spend some time making sure that you have recovered your breathing before you then repeat those deep breaths again. And that's that top cycle of breathing control, deep breaths, breathing control, deep breaths. If you feel that you've got some mucus that's moved and it's in the top of your chest, and you know that it's going to start making you cough, you can do something called a huff. And if it's higher up in your chest, you can do what we call a small, long huff. So that's a small breath in and a long breath out, but it has to be under pressure and your mouth is open. So I will demonstrate for you. So small breath in and a long breath out. If there's nothing there and you don't feel as though you've got any mucus that needs to move after you've been in one position and you've done that cycle for about 5 minutes, then you can try what we call a big short huff. And this is a little bit like the start of your breathing tests. So you take a big breath in and then it's short, sharp huff out with your mouth wide open. Okay, those techniques can be a little bit more effective at moving mucus rather than coughing alone. Okay, the other technique that we can use to help move mucus, oh, sorry, next slide, please. Thank you, is what we call positive expiratory pressure. And a simple way of doing this is a little bit Blue Peter style. So I've got here a 2-pint milk carton and I've filled it half full with tap water, and I've got a bit of tubing, but you can use a straw as well. And what you do is take a breath in and then put your mouth around the tubing. Don't take the breath in when you've already got your mouth round there. So breath in, make a seal, and then blow as hard as you can. And you can hear, hopefully, and see some of the bubbles that I'm creating in the water. So what happens with that is as you're breathing through the tube, it helps to splint your airways open slightly, and the vibration from the bubbles that you're generating in the water can help to move that mucus. So that's something that you could try at home. If you feel that that is helpful, then there are devices that you could request either from your respiratory team or your GP that don't involve messing around with bottles of water, that can help you to expectorate a little bit more easily. Hydration and humidification are really important. If you're dehydrated, your sputum can become really quite sticky. So it's important to look at how much water you're drinking, not just tea and coffee. You might have already found that when you've come out of the shower, the steam can help loosen up those secretions, and it can be easier to actually clear your chest after you've had a shower. You could use the old-fashioned hot water in a bowl, towel over the top, and breathe in that steam. Just make sure that the water's not boiling. If you have really glue-like secretions that are just not moving despite everything else that you've tried, then sometimes we might try a saline nebulizer, which is salt water through an air compressor that you can breathe in, that can help to move that mucus. There are also medications called mucolytics that your doctor could prescribe. Percussion is something, as I say, that you might be aware of. It's not something that we do routinely, but there can be a place for it. We have to just be a little bit careful of certain things like osteoporosis, which is brittle bones. And obviously it's easier for you if you're able to do the techniques that I've just shown independently rather than relying on somebody else to help you. So we come on to pulmonary rehab, which has been mentioned a couple of times, and it's an exercise and advice program for people with lung disease. It's individually prescribed. It used to be pre-COVID a group program. We have mostly started to go back to having groups, but there may still be an option for an individual program to be prescribed for you at home if you're uncomfortable with going into a group situation. Most programs, most programs require referral from your GP or practice nurse. There are lots of different benefits to exercise, and I won't go through all of these, but as you go through them, you'll be able to see that there are some physical benefits, but there are also some psychological benefits to exercise as well, which are not to be underestimated. These two cycles show you the pitfall that you can get into in terms of not exercising. It's very cruel that the one thing that you struggle with, which is activity and breathlessness, is the thing that we're then asking you to do more of to help you. But the less activity you do, the weaker your muscles will become. That makes them more efficient and you will feel more breathless. The stronger and the more efficient you can get them, the less breathless you will be with activity. So how much exercise or activity to do? How hard do you push yourself and how often do you need to do it? So we tend to advocate two different types of activity. One is aerobic activity and the other is muscle strengthening exercises. Ideally, you need to be aiming for about 150 minutes a week and at least 2 days a week. That can look a little bit daunting. And so if you wanted to start small, just 5 minutes makes a difference. During COVID, everybody was doing count to 5K. Nobody was starting off with the 5K. They were starting very, very slowly. And that's the case with all activity. How hard do you push yourself? So if you've done some of the walking tests that Joe and Jenny were just talking about, then they would have probably put this scale underneath your nose at some point and said, how breathless do you feel? You need to be looking at number 3 to number 4. So we need you to be getting out of breath to a point where you're still in control and you're still able to hold a conversation. And we know that getting out of breath to that level will be effective. In terms of strengthening exercises, again, I'm not being sponsored by the milk industry, but milk cartons can be used for lots of different things and you can turn them nicely into hand weights because they're quite easy to hold on to. So that gives you a rough weight on there in terms of the size of the milk bottle. And what we would advise you to do is start off with a smaller weight and do the exercises in sets of 10, building up to 30. Once you can manage 3 sets of 10, you'd increase your resistance. In terms of the advice part of pulmonary rehab, this is usually delivered by a multidisciplinary team of health professionals. And these are usually some of the topics that are covered during a standard pulmonary rehab program. So in conclusion, exercise and activity is safe and it can help with your lung disease. Have the confidence to give it a try. And just remember that being active has both physical and mental benefits. It can help you take back control, be more independent, and can help you live well for longer. And those are just some references for you to look at. Thank you very much.
Thanks very much, Sam. Such a lot of really helpful information that's practical and people can take away from the day. Can see there's lots of enthusiasm for your talk, as there was for the last one about oxygen. So now we're going to move on to some information provided by Dr. Lisa Spencer, who you've already met today. So Lisa is one of our national experts in interstitial lung disease and a wealth of information. So I will hand over to Lisa now to talk about lung transplantation.
Thank you very much, Sarah, and hello to you. And hello to all the patients again. I'm back again. Okay, so I've been asked to talk a little bit about lung transplant. Next slide, please. This will be quite a canter because it's quite a big topic, so I'm only going to be able to pick off certain things to discuss with you, but hopefully if there's questions later, I'll be able to answer some questions. So first of all, obvious question to ask, why do we do lung transplants? Well, they can improve greatly the quality of life for a patient after the transplant, and in some cases they can offer improved survival. I think it's quite important though to understand that it's not an appropriate option for everybody. The criteria to receive a transplant are very strict. And this is in part because we don't do that many lung transplants in the UK, or indeed do the world do many lung transplants. So in the UK, we do between 150 and 200 procedures a year. Now, this is very small if you can compare it to other solid organ transplants like hearts, or in this case, I've put the number for kidneys. We do 10,000 kidney operations, kidney transplants a year, and we do less than 200 lungs. And you might think, well, why is that? Well, at the end of the day, it comes down to donor shortage. There's just not enough suitable donor lungs to go round. So what does that mean for patients with lung fibrosis? Well, to put it in perspective for you, our biggest single disease entity that we deal with in pulmonary fibrosis umbrella group of diseases is IPF, idiopathic pulmonary fibrosis, and only about 1%, that's 1 in 100 of patients with IPF will ever get to a lung transplant. So the small number that are done has a big impact on all diseases. It particularly affects IPF patients because the average age of diagnosis is a little bit older, and as you get older, the chances of getting a transplant get slimmer and slimmer. Next slide, please. For those of you who are interested in looking for information on the web about transplant, there are quite a few. There's a good NHS site, but there's also a good site which is the NHS Blood and Transplant website, and I have taken this graph from that website. What this graph shows you is on the vertical axis, it's telling you the number of transplants that we do in the UK each year, and on the horizontal axis, it's giving you the years. So the left side of the graph is 2012, 13, and the right side of the graph, at the furthest right bar, is 2021 to 22. So each year is shown. And what I wanted to show you with this graph is that the number of transplants are a bit variable, but it's usually between 150 and 200, and that the pale blue part of the bar represents the number of double lung transplants. So that is the commonest procedure that's done in the UK. The dark blue line at the bottom is the single lung transplant numbers, and you can see that's a lot smaller. And the tiny, tiny grey bit at the top of the graphs, each bar's got a tiny grey specky bit, and that is the number of heart and lung transplants. So that's where you take recipients, both lungs and the heart, donors, both lungs and heart, and put those into a new patient. So that's done very rarely, and those transplants therefore involve potentially 3 organs, 2 lungs and a heart, and they will often go to the very young patients with cystic fibrosis only. So there's not many of those operations done. Next slide, please. So let's think about who should be referred for a lung transplant. Well, first of all, the patient's got to consider it an option for them, of course. But broadly, it'll be patients from the lung side with advanced lung disease, which is progressing despite maximal treatment. It's really important before you refer for lung transplant that you've tried everything you can to try and keep the patient as well as you can, and that they're still progressing despite that. Those are the sort of patients who need referring. They are likely at this point to have significant symptoms and likely to be using some form of oxygen. It might be oxygen for exercising and walking, ambulatory oxygen, as was just covered in the oxygen session, but they're likely to be using oxygen. They could be on long-term oxygen as well. The form is the same for all the transplant centres in the UK. It's a very long and a very detailed form, but this is very important because patient selection is absolutely key to a good outcome from transplant. And that is why a lot of patients don't get the chance to proceed, because they just don't have all the right characteristics to have a successful outcome. And that's what's really important at the end of the day, is having a good outcome after transplant. And your lung team will usually discuss with the patient if they feel that a transplant conversation needs to happen. But if you're not sure and you're interested to know, you can also always ask your clinical team at any time if they think that that might be an option for you. Next slide, please. Next slide, please. Thank you. So, in the UK, there are 5 transplant centres. I've listed them there: Glasgow, Newcastle, Manchester, Birmingham, Papworth in Cambridge, and Harefield in London. Technically, a patient can choose which centre they go to, but in practical terms, this is actually quite tricky. I mean, if you live halfway between Manchester and Birmingham, then choosing either one might be a reasonable choice. But if you live in the Midlands, going up to Newcastle or Glasgow is going to be a very long journey. Now, the issue being that after you've had a transplant, you have a long, well, the follow-up period is for life, but you have to have a lot of visits back to the transplant centre. And also getting there to get your transplant operation in an urgent situation, if you've got a very long journey, that would be quite difficult. So although you have a choice, the practicalities are that most patients will end up going quite reasonably, I think, to the nearest centre that they can. On the left-hand side of this slide, there is a white diagram with some boxes in it. This outlines the sort of transplant journey or transplant pathway or pathway to a transplant. And it consists of 4 aspects. There's the assessment phase, the listing for lung transplant, the transplant itself, and then the follow-up phase. If your team refer you for a transplant assessment, usually you will hear back within about 6 weeks of the team receiving that referral. It might be a no if you're not suitable and they can see that straight away, or it could be a yes. And if they give you a yes, they will then arrange for you to be seen in their transplant outpatient clinic. And if they think that you're still suitable after that visit, they will then arrange to bring you in, usually within 8 weeks of getting the referral letter, for some more tests, which can take between 2 and 4 days. And those tests are really important because what they're doing is they're checking out, obviously you've got severe lung disease, that's why you're there, you need a new pair of lungs or a new single lung, but they want to know all your other organs are in good state so that you can cope with the operation and get through it very well. The other thing to remember is that when you're on this assessment pathway with the transplant centre, you're under constant review and your situation can change. And if you deteriorate to a point where they think you're then unsuitable to proceed safely, they will sometimes take you out of that transplant pathway. The other thing to remember is that if a patient wants to get off that pathway at any time, they can, and they just have to say that they would like to consider that. After you've gone through all the tests, the transplant team will then look at your case within a multi-professional meeting and see whether they think that you're suitable to proceed for listing. If you're thought to be suitable, you will then be offered an appointment with one of the thoracic surgeons who might be doing your operation. And it's just the surgical team usually who have the final say on whether they think they can get you through the operation safely after they've counselled you appropriately. After that, you can become listed. And then obviously the next stage would be being called in for your operation. Next slide, please. So you're now on the waiting list. How long might you wait for your transplant? Well, that's a difficult question to answer because some people get their transplant quite quickly, within a few months sometimes. And some patients, it takes almost literally years to get a transplant. It can be quite slow. Things that affect this are obviously the amount of donor lungs that we have available. Also, the size of your lungs can be important because a pair of lungs could come in and you may have very big or very small chest cavity. And so a lot of the lungs that come in because you're different size to normal might be unsuitable for you. Also, things like blood groups, whether you're A, B, O, that can affect the availability of lungs because the different blood groups occur in the population at different rates, and you've got to be blood matched when you receive an organ. So there's lots of factors that can be involved. And this table is taken again from the NHS Blood and Transplant website, and I've circled in red a number 594, and that is between 2018 and 2021. That was the median, the middle time that a patient might wait for a lung transplant. So that's about 1.5 years. But remember, there are lots of numbers either side of that, but it gives you a bit of an idea. It's really important that you stay in good shape when you're on the waiting list, because if you let things go, don't look after yourself, you can be reviewed and removed off the list because you can become unsuitable. So really important to stay in as good a shape as possible. And they support you to do that with transplant centre. They give you advice about how to keep well. Next slide, please. So you're on the list and you get called in. What's going to happen? So if you end up on the transplant list, you're given a pager like a doctor's pager or a telephone pager, and you can be called in at very short notice. This is because organs become available at very short notice and unpredictably. And I have to say, call-ins can be an emotional roller coaster for patients. There are basically three possible outcomes to a call-in. One is what they call a no-show, which is slightly unfair because it just means that they could not contact the patient. They've tried to get the patient and they couldn't contact them. Perhaps the pager battery's broken, perhaps they're out of range, they've gone abroad, they've forgotten to tell a transplant centre, they've gone away, they've left their pager at home, the patient can't be contacted. The second outcome is what we call a false alarm, which is when the patient is brought in, there's a lung coming in that might be suitable for them, but they are no longer fit for surgery. Perhaps they're in the middle of an infection, they're just not right, and they don't want to proceed because they're worried about the risks. And that might be a false alarm call. Or on the other hand, the organs that they think are coming, when the transplant team go out to retrieve them from wherever they're getting them, they find that they're just not quite as good as they thought they were, and they had to reject them because they don't want to put organs that aren't as good as possible into somebody else. And in that case, the patient would get sent home if either the organs weren't right or they weren't fit for surgery. The third outcome, of course, is, hooray, you get your transplant. Next slide, please. So let's have a little think about the operation. You're getting your transplant now. So there's no two ways about it. This is a big operation. Whether it's a single or a double lung, it's a big operation, and it can take anything between 4 and 12 hours to do. Imagine standing up and operating on someone for that length of time, and imagine the poor patient undergoing, obviously they're asleep, don't worry, you're asleep, but imagine going through surgery that long. That's a long time to be in surgery. So basically, I've shown a little picture there. This is the sort of incision they might do, which is called a thoracotomy incision down the side. That's the one they might do for a single lung transplant. The procedure for opening the chest for a double lung transplant is slightly different. But basically, they will do an incision, take out the old lung, reconnect the new ones, reconnect the main blood vessels and the breathing tubes. After the operation, the patient might be on intensive care, ventilated for a few days, between 1 and 7 days, and they'll be in the hospital for at least 2 to 3 weeks because it is a big op. Now, I mentioned about the follow-up phase with transplant. Follow-up after a transplant with the transplant centre is for life. You are theirs for life. You are committed to seeing them forever because you need their help in managing your transplant over the longer term. After discharge, after discharge from hospital, the visits are very frequent. It's weekly for quite a few months, then 2 weekly for quite a few months, and then it might drop to monthly for quite a few months. And it really is quite an intense period of follow-up, but that's very important because they want you to help you look after your lungs and make sure everything's okay. You're looking at months to recover from this operation, and some patients don't realise quite how much medication sometimes I think they will be on. They will be on a lot of medication, particularly in the early post-operative period. It does reduce a bit over time, but you'll be on drugs to prevent rejection of the new organs, and then drugs to prevent or to treat infections that you might be at risk of getting. Next slide, please. So there's a lot of drugs that you're on and a lot of commitment to taking the medication. What about survival? Now, this information could be quite hard for some people to take, but I think it is vital that patients are fully consented and aware before they commit to having a lung transplant, because you need to go into these things with your eyes open, don't you? So this graph is taken from the international database for lung transplant. On the vertical axis is percentage survival, and on the horizontal axis is time. Now, there are several coloured lines that you can see, and each coloured line represents a different disease type. I have picked the line that's sort of in the middle, which represents some of the lung fibrosis types that are transplanted. It's the sort of blue line, and I have put 3 black circles along that line. I have put the circles on at 10 years, at 5 years, and at 1 year. So if you move from 1 year up to the blue line and go across to the survival bit, you can see that survival at 1 year after a transplant is about 85%. At 5 years, it's about 50%, and at 10 years, it's about 25%. Now, the top line here is actually representative of the cystic fibrosis population. And although fibrosis is in the word cystic fibrosis, it's a completely different disease and nothing to do with the sort of fibrosis that we're talking about today, really. And it's a disease often seen in young people. And you can see that they do a lot better, and that's predominantly because they are younger. So their survival at 9 years is at 50%. So they just do a lot better because they're younger. There is, however, these are mean numbers, average numbers, and there's a large variation. And there are patients out there who are older with lung transplants who have lasted a long, long time. And there are patients who are younger who've gone over 20 years with lung transplants now, and it's getting better all the time. But these are the hard facts, and this is something you need to get your head around before you go down this journey, I think. Next slide, please. So those survival figures may or may not surprise you. You might wonder what affects survival after lung transplant. Why doesn't it last forever? Like a kidney transplant seems to go on and keep giving for years and years, 20, 30 years. Well, it's because the lungs are interacting with the environment, and that means that bugs and dust and things go in. Now, in health, we kind of manage that, but when you've got a transplanted organ, it can't handle it as well. During the first year post-transplant, most common reasons that someone might not do is early graft failure. So you can sometimes put a set of lungs in and they just fail to work, and that's very, very difficult to handle. Also, patients, when they get a new set of lungs, can acutely reject them because they can their body has not responded perhaps enough to the immunosuppression, and they reject the lungs. There's also a big risk of infection because your immune system is suppressed, so that you will accept the new lungs, but that leaves you vulnerable to infection, so that can be a problem. And some patients, just after the operation, they just can't cope with it, and their organs fail. These are small numbers that this happens to, but that's the early problems that you can see. Later on, infections are a big issue, and the drugs that you're on to suppress the immune system can open up your chances of getting infection. And also there is a small instance of cancers, lymphomas occurring, again related probably to the immunosuppression. And then some people get, for example, kidney damage from some of the drugs that they're on to prevent the rejection. So it's quite a complex process, and these are the types of things that affect survival. Next slide, please. So in summary, lung transplant is an option. It's a good option for some people, but it isn't available to everybody. And there's a good reason for that, because we have to make sure that we take those people forward with these limited resource organs who are really going to do well with those organs and get through and have a really good outcome. It can absolutely transform your life. You can go from a patient who's extremely breathless on oxygen to someone who is actually going on to compete in Olympian type sporting events like athletes do. And there's a couple of posters there on the right hand side of the slide from the transplant games. So you can have an amazing turnaround. But it isn't a process that's great for everyone at the end of the day. And if you're not selected for transplant, I can imagine that is incredibly hard. And I've had patients turned down for transplant over the years. But actually, the team are doing that because they really don't think you're going to do well with the transplant, and you're better in a way with what you've got, which is very hard to accept when you've got extreme symptoms, I realise. Okay, so I think that's my last slide. The next slide is, I think, this one. Thanks very much. Happy to answer any questions.
Thanks, Lisa, for that really informative talk. It's definitely a difficult subject to hear about, isn't it? Really hard information to hear, but knowledge is power. So knowing about your options is absolutely key. And there is a lot of enthusiasm for your talk. I can see lots and lots of thumbs up and claps, which is great. So we're on to our final speaker of this pre-break session, who's Dr. Mahin Ahmad. Mahin is a specialist registrar in respiratory medicine and was a medical student in Liverpool, has trained in Liverpool, and is currently working at Aintree Hospital as a clinical fellow with the interstitial lung disease team there. So welcome, Mahin. Come and talk with us about clinical trials in interstitial lung disease.
My name's Mahin. I'm one of the clinical fellows and registrars in Aintree, and I'll just be shining a light on clinical trials for the last 10 minutes of this session. So I'll just be going over what a clinical trial is, how we've benefited so far, and how you can get involved in the current and upcoming trials. So clinical trial sets out to answer a specific question. Does this intervention or treatment work specifically for this condition? And more importantly, is it safe? So we most commonly test drugs, and these can be medications, but we also look to find other forms of treatment. So in respiratory, we always look at inhalers or nebulizers. We can look at injections as well. So this could be in the muscle, under the skin, so subcutaneously, or through the vein intravenously. We can test new tablets, or we can even test medications that's used for other conditions and see whether it works for us. So a current example is a study that our centre is involved in, and other centres may also be involved in, called TIPAL. And it's testing the medication lansoprazole, which is widely used for heartburn, and seeing whether it works effectively in idiopathic pulmonary fibrosis at slowing down the scarring as well. And some of you might even be involved in that trial currently. Well, once the question is set, our main priority is your safety and your rights. And that's why all clinical trials have to be ethically approved before they go ahead. And that means just being monitored by the relevant regulatory bodies to make sure it's safe. So on the process of safety, all clinical trials occur in phases. So this was a lot more colourful when I had it, but obviously the slides have changed a little bit. So clinical trials occur in phases. We start off with a phase 0 or 1, where we're testing the drug on a smaller group of people. And this is just to find out the safety profile of the drug, what's a good dose that's effective, and whether it shows signs of working on the condition. It needs to pass each stage or each phase before it can move on to the next. And once we get to the phase 2 and phase 3 trials, we're then testing the medication against the current standard treatment or a placebo version, which is an inactive version of the medication, to see, is the drug effective? And these are tested on a larger group of volunteers, and they can be national or even international. And if the intervention is found to be effective at this stage, then it can be reviewed and approved to be used for that condition. For clinical trials to go ahead, though, we need to recruit a minimum amount of volunteers to participate. And this is to make sure that the results that we gather are reliable and accurate. And if we don't manage to gather enough volunteers, there's a chance that the trial might not be able to go ahead, or that the results that we get can't be used in clinical practice. So a recent example of that is the Trail 1 trial, which was looking at pirfenidone, which is an anti-fibrotic medication used in IPF, and seeing whether we could use that for fibrosis due to rheumatoid arthritis. But unfortunately, the COVID pandemic hit and we weren't able to get the numbers we needed. So although we learned a lot about the drug and it did show that it was effective, we just didn't get the accurate results that we were after. So the question that you'll be asking yourself is, why should I get involved in the clinical trial? How does this benefit me? And why am I needed? So the main benefit that you're going to get is that you get direct treatment, direct access to new potential treatment that could work for you. So not only do you get a head start, but you also get closely monitored by the research team. The downside is you may be placed in the placebo group, and with all treatment, there may be some side effects, but you get one-to-one experience with us. You get to work closely with our doctors, nurses, and this is a picture of our local respiratory research team. So you've got the two Joes, we've got Lucy, we've got Dr. Kwok in the middle, and Brogan on the right-hand side. There may be extra visits to our clinic appointments, but you may be offered tests that aren't available in your normal clinic appointments, and any travel expenses are reimbursed by the study itself. And I'll just add a little side note: if you're involved in a phase 1 trial, which is the testing on a smaller group of people, they usually offer quite a significant stipend, which is almost like a pay for your inconvenience to be part of the trial. So an upcoming phase 1 trial that we're hosting at the Royal Liverpool Hospital is looking at an intravenous medication for idiopathic pulmonary fibrosis. And if I'm not wrong, they're offering about £2,500 for people if they're involved in it. So if anyone's looking for a New Year bonus, watch this space. So how have we benefited so far from clinical trials? So some of you may already know that we've had 2 landmark trials in 2014. So we've got the Ascend trial, which was a phase 3 trial looking at pirfenidone in idiopathic pulmonary fibrosis. And we had the Impulses study in 2014 as well, looking at nintedanib in idiopathic pulmonary fibrosis. They both recruited hundreds of people, and the study was comparing these treatments against a placebo over the course of the year. So on the graph, you can see on the bottom horizontal axis, the time, so over 52 weeks, and on the vertical axis, they were measuring the change in your lung volume. The top line is looking at the effect of the medication, and the bottom grey line is looking at the placebo group. So the groups are split 50-50. They were randomized in both groups, and the participants and the team weren't aware of who was in each group. So that's called blinding or double blinding. And both these studies showed that the medication significantly slowed down the disease process or the scarring process, which meant that you had more lung volume if you took the medication than if you didn't by the end of the year. And because of this, these 2 medications were then approved to be used in idiopathic pulmonary fibrosis. And although Ascend was done in America, Impulses was international. And actually our centre in Liverpool was involved in that. So we had some of our local Liverpool patients in this international study. And what this study allowed is, at the end of it, it allowed some of the patients to have early access to nintedanib before it was officially approved. Approval takes about 18 months to 24 months to go through the process and the paperwork. But the study, if you're part of the study, regardless of what group you were in, you could have early access. And I've been told that the first patient to get access to nintedanib after the study was a local Liverpool patient 18 months before it was widely given out to the rest of the public. So you do get direct benefit, and there are perks to being involved in the study. Following on from this, nintedanib then was tested in other fibrotic lung diseases, not just IPF. And in 2019, we had 2 further studies, the Census, which looked at nintedanib in systemic sclerosis, lung fibrosis, and the IMBIL study, which looked at nintedanib in all progressive fibrotic lung disease that wasn't IPF. And again, a similar design, so taking the medication over 52 weeks, looking at the drop in lung volume, and both studies showed that nintedanib significantly slowed down the scarring process. And following this, earlier this year, nintedanib was then licensed to be used in all progressive fibrotic lung diseases, which is a huge step in the management of lung fibrosis, considering 10, 12 years ago, we didn't have any options. However, although this is a big step, the options for managing lung fibrosis, the actual disease itself, is still limited, which is why there are still ongoing clinical trials and many more trials that are needed. Oops, sorry. So the more trials we do, the better chance we have of trying to find a better treatment than nintedanib and pirfenidone. Sorry to the companies that make those, but also other forms of treatment. So some people might have tried these medications and they don't suit them because of the side effect profile, or they're not eligible for them because of other medical conditions they may have. So we're always looking for alternative forms of treatment, but not only treatment, trying to find out what causes the lung fibrosis in the first place. Are there any markers that can predict who gets fibrosis, and also managing the symptoms that come along with it? So this table is just a handful of studies that are happening nationally. The ones in red are the ones that our centre's been involved in the recent past and currently. And each column shows types of studies that we're doing. So the first column is looking at tablets for pulmonary fibrosis. The second one's looking at inhaled therapy. The third column's looking at medications through the vein. And the fourth column is looking at other markers, other forms of monitoring. So I'll just pick out a few examples that are currently happening for those people that I've sparked a little bit of interest in. So in the others column, you can notice the BILD UK, the BILD UK study at the bottom. So this is a study that looked at biomarkers for predicting who develops lung fibrosis. Above that is the IFIL study, which is an upcoming study that our centre is hosting, and that's looking at remote home monitoring of your lung function with handheld spirometers. The picture at the top of that is an example of a handheld spirometer. So people come into clinic to and have their lung function done with the big machine. And this is seeing whether it's effective to do them at home. Is it better for you? Does it provide the same accurate results for us? That's just one example. The phase 1 study that I spoke about earlier is actually the Zampilimab study, testing this monoclonal antibody to see the effectiveness in IPF. So that's the one that's upcoming in the new year. Galactic in the inhaled column is, we've just finished recruitment actually. We've got the minimum number of patients for this, and it's looking at inhaler therapy in IPF. And then TIPAL I've touched on. The last one I want to talk about is Pacify. So not only, like I said, we're looking for treatment for the scarring itself, but also how to effectively treat the symptoms, which are a bigger burden on people with your condition. So cough is a big example of that. It's quite a debilitating symptom to have. And there's no effective treatment at the moment to help that. So Pacify is looking at the medication morphine that's used widely for pain and breathlessness, and seeing whether it's effective at managing cough. So it's just a small example, and different centres across the country will be doing different studies. So as you can see, there's many trials available, and each one is to find better and better treatments to better your overall care. There's lots more upcoming in the future. And it's an exciting opportunity, I hope, for you that that you get to know more about the condition, you get to be involved in new treatments that are upcoming, and you get to share the joy in helping people who may develop this condition in the future. And I really hope you can join us for this. So if I've sparked an interest, get in touch with your local team. I know a lot of questions from beforehand were, how do I get involved in clinical trials? Come to us, ask us what's going on, and we'll be more than happy to talk to you about it. Because remember, we can't do this without you.